With that, I'm going to go ahead and welcome our moderator and our panelists today. I'm going to ask them to kind of just wave their hand while I call out their name and position, and then I'll turn it over to the moderator. So I'm going to start with Devin. Devin Cantwell is with the Amarillo Police Department. He is the crisis intervention team coordinator. And then we have Kathy Tortoreo. She is the Crisis Services Director and a licensed professional counselor at Family Support Services. And we have David Bustos, who is on the Mobile Crisis Outreach Team for the Texas Panhandle Centers, and he serves the 21 counties in the Texas Panhandle. And we have Jennifer Oliver. She is the inpatient therapist over at Northwest Texas Hospital Behavioral Health, previously known as the Pavilion. And last but not least, we have Meg Chard-Jean. She is the Master's in Social Work Field Director for the WT School of Social Work. So Meg, you have the Zoom, and we can go ahead and get started with our panel discussion.
Good morning. Thank you again for everybody for coming this morning. The purpose of this morning's panel is to try to get more information out to providers on what to do during a moment of crisis, especially mental health crisis, and how to best get a better handle on what resources do we have currently available in the Amarillo area for your clients in particular during when they're having a crisis. So we wanted to connect you with and hear directly from those providers that have those resources for you. We're also going to be providing you with a handout during the presentation that also provides you with a list of other resources as well. But we're going to be talking to the 4 agencies, and hearing from them exactly, and also talk about specific situations that you guys are probably running into more frequently than others. So let's hear from David first. We're going to have everybody talk briefly about their agencies and specifically what they do and how to access their services during specifically those moments of issues where maybe somebody is suicidal, they're having acute crisis. So let's talk to David first and let him tell you a little bit about mobile outreach and what his agency does. So David?
Hi, good morning, everyone. So again, my name is David Bustos. I'm the supervisor for the Mobile Crisis Outreach Team. So we respond to people who identify themselves to be in crisis. Now, a crisis is anybody who's homicidal, suicidal, or has a mental health decompensation. In order to access our services, you're going to start by calling our Avail Crisis Line, which is a third-party hotline that will screen the information and determine whether we need to be activated or not. That number is 806-359-6699. And what they're going to do is they're going to screen what's going on, determine the severity of how we need to be activated. And if they determine we are activated, we'll be called out to go do that assessment. And those assessments can come any time of the day, 24/7, because we are on call for the entire week, even on holidays. So if we do get called, we're going. They're going to determine whether it's going to be an urgent response, which means we have 8 hours to respond to that crisis, but we don't ever want to take 8 hours to respond to any crisis, or an emergent, which is a very immediate crisis, which in that point we have an hour to respond to that crisis. So if we get that call, we're going to do our assessment and determine one of 3 things. One is if this person needs to be some kind of inpatient hospitalization. 2, they don't need to be hospitalized. I mean, they could benefit from immediate crisis services. So we kind of expedite our intake process through our crisis services. Or 3, everything was okay, and they didn't need services at all.
Thank you very much, David. We will move over to Devin Cantrell from the Amarillo Police Department, and he's going to tell us a little bit about CIT.
Yeah, so CIT was formed here in Amarillo in 2007, and we were one of the first police departments to kind of embrace that model of crisis response in this area and even across the state. There's even some larger cities across the state that haven't had a CIT team or a CIT response as long as we have here. So we're very fortunate here. Our Chief Birkenfeld, at the time was a lieutenant and really spearheaded the effort to form this CIT team. And so I'm excited to be back part of it as a supervisor. I was a CIT officer myself from 2008 until 2014. But mainly what our goal is to provide that crisis response outside of the normal thinking of what policemen do. We want to be a community partner, and we want to be a caretaker of those in our community that need mental health resources. And so we have right now I have 5 full-time CIT officers that work. I have CIT from 7 in the morning until 4 in the morning. So I've stretched my 5 full-time officers out as much as possible to try to get as much 24-hour coverage as I can. But mainly what we want to do is provide that response real time in the field to those clients that need mental health resources, and provide a response that, you know, maybe a traditional police officer doesn't have all the training that my guys have. And we want to provide those resources as well as diversions if we can, to get them connected with mental health resources in the field. And so that's why with the Intercept program, which we started back in 2016, we've partnered with TPC, full-time mental health professionals that ride with 2 of my officers every day. So with that, we can get connected with MCOT. We can get connected with, you know, if that person is a primary care physician or psychiatrist that they see, we can try to get those connections made in the field where we don't have to do an emergency detention, and maybe just get them, you know, if it's a medication issue or maybe they've run out of their medication, my officers will actually go get their medication refills for them from time to time. So it's just a real tailored response to those folks in our community that need those crisis resources.
Fantastic. Devin, can you explain to those who are attending, how can we request a police officer with mental health training, rather than, like, if we make a call to 911, but we want somebody with somebody from the CIT team, if available, to come? How do we make that request?
Just like that, you would tell them, you know, kind of inform the dispatcher, because they catch every call that comes in, so they're not always thinking in the zone of CIT at the time. They get, you know, the gamut of calls that come into our call center. So just remind them, say, hey, you know, I'm with such and such, or I know this person has a mental health diagnosis. I would really prefer if a CIT officer could be on the call, because they've worked with them before, or I'm recognizing signs and symptoms of this person that I think they need a mental health resources. And so if a CIT officer is available, could you please send them? So it's usually just as simple as that. And we want people to call our call center in an emergency and when something's happening, because, you know, just due to manpower issues, I only have 5 officers. So, you know, it's highly probable that I might have an officer off that day and one at training, and then my other 3 are on other calls. And so if there is an emergency, we want to send the next best thing, which is one of our APD officers. And I want to say that with a caveat. I am confident that any of our APD officers are competent and equipped to handle any CIT call. We like to have the team that's tailored to that and works in that realm every day to both free up our regular beat officers, but as well to, you know, provide that tailored response. And a lot of times that relationship and rapport, because a lot of our mental health consumers, we've dealt with them before, and that relationship's there, and we can get a lot of ground covered in lieu of, you know, a new officer showing up at the house and that person doesn't know them. So again, if there's an emergency or something, 911, request a CIT officer, but if there's one not available, any of our officers are equipped to handle that and get things stabilized. And a lot of times my officers will get on the call when they get freed up, or they will, you know, make a phone call and help them get connected with the resource that they need. And they work really closely with our regular patrol officers.
And just to clarify, is there a direct line for CIT, or do we need to call the police general line or 911?
No, there's not a direct line. Like I said, I have a desk, but a lot of times I'm out in the field with my officers trying to help, since there is just 5 of them, really 6 with me. So there's a lot of times when we're all in the field helping out. So if it's a, you know, if it's a question or you'd like to have a meeting or something, I can drop my business card on here. You can give me a call or leave me a voicemail or an email. But in an emergency situation, we'd always prefer you to call the call center.
Okay, fantastic. Thank you, Devin.
Yes, ma'am.
Kathy from Family Support Services, can you tell us a little bit about the services at Family Support Services and what you guys can offer to Amarillo in time of an emergency?
Sure. Family Support Services is a community agency. We do have a mental health and wellness department. Used to call it counseling or clinical, but we've, you know, kind of rebranded it mental health and wellness. Our crisis division, which I'm the director for, focuses specifically on domestic violence and sexual assault. So there's frequently concurrent mental health that goes along with that. However, if it's someone that's in a mental health crisis because of a particular diagnosis, hearing voices, having suicidal thoughts and ideations, our agency does not do specific assessments in a crisis emergency situation. Typically, what we will do is we'll have a person be with that, like that walk-in, and then we'll explain what the CIT or the MCOT process is, and we will contact them to come to our agency and do an assessment with that individual. We utilize their, and I've seen CIT in action, and I will say such professionalism and respect and compassion. So I'm just really impressed with how CIT does that. So by utilizing those community resources, we want to be a conduit to get that person the help that they need, because as mental health professionals, many of us recognize how important that is to do that in the moment. Additionally, we do have our 24-hour crisis lines, which are run and operated out of our emergency safe house. We used to call that our domestic violence shelter, but now again, because we focus on other individuals, sexual assault and human trafficking. However, it is common for people to have that crisis line number, and it's not about domestic violence or sexual assault. It's about suicidal thoughts. It's about some other things. So our advocates are trained to field those calls to help create a calming situation on the phone, and then also give additional resources. Ask about family supports, and you know, can someone take it to the ER right now? Can you call a person who's very close to you? Do some talking through that process, but also make sure that to give that person very specific referral information, so that in that crisis situation, we can assist them. And it's not unheard of for us to what am I trying to say? Be the conduit between, you know, someone's calling and it's really an emergent situation. And we have had advocates that have had to call 911 and say, this is our situation. This is the phone number we have, asking the person in crisis, hey, we want to call someone to get out there to you so that we make sure that you're okay. And if they give us the address, then we've requested that emergency services go out and meet them at their home so that they can get an assessment that way as well. So we definitely do a lot of referrals to Northwest ER so that they can get assessed, and then of course utilizing MCOT and CIT, which is very critical. So I will give our toll free crisis number, which is an 844 number, which still freaks me out a little bit. So it's 844-363-4666. 3452. That's the toll-free number. Our local number is 374-5433, 374 life. So that is a way to access us. So through our crisis services with domestic violence and sexual assault, we have advocates that are actually dispatched to assist those individuals. And again, a crime having been committed, many times there are concurrent mental health issues. And so we'll ask those questions, and certainly the sexual assault nurse examiners additionally. And then of course, if they're in the Northwest ER, then they're being asked questions about how they're doing and if they're having suicidal thoughts. And so then we have those professionals right there that we can refer to. And then if, as an advocate, we're there on site, then we can just provide that support figuratively and sometimes physically hold that person's hand.
Right. Yes, since I am one of those volunteers,
Yes, you are.
and we're always looking for more volunteers for that particular program. If you're interested, you can always talk to Kathy or reach out to Kathy after the program. But that is a viable program. Unfortunately, sexual violence and sexual assault is a reality, and it does come along with a lot of additional trauma, and that trauma has to be followed up. And family support services does provide that trauma care that happens after a sexual assault. And so it's not a one-time deal after a sexual assault happens. Family support services provide that ongoing care for somebody that suffers a sexual assault in Amarillo area, Mandel and Potter County. So that's something that obviously family support services does very well. So last but not least, Miss Jennifer Oliver from Texas Northwest Texas Hospital.
Yeah, we're still getting used to that. Yes. Yeah.
I always switch it around. Yes.
Yes. Also known as the Pavilion. I am a unit therapist here. I work on the older adult and medical unit. Now our hospital is designed for inpatient and outpatient services. So inpatient services are for those that have been deemed a danger to self or others, or their symptoms are so severe that they are unable to care for day-to-day needs, and we look at that as kind of an overall mental decompensation, needing a level of care in a secured environment. So what that provides to them is daily psychiatric visits from a physician or a nurse practitioner, medication management, and along with therapy services. That includes group therapy daily, individual therapy, and family therapy as needed. The goal of the inpatient level of care is overall stabilization. So to reach a place of baseline to where we can then refer out to providers in our community, and they can then step down to a lower level of care. And then kind of at that time, they can be considered for our outpatient program. That's a program where they go throughout the week. They attend group classes. They continue to see a physician and have medication monitoring. It's a great step down, especially for those that were in an inpatient setting. That way they can continue to have some care daily at a higher level, but they get to go home in the evenings and they stay at home. In order to access services here, I always recommend calling our main number, and that is 806-354-1810. I'll drop that in the chat as well. There's a variety of scenarios that can lead to someone needing an evaluation at the Pavilion or behavioral health hospital. If you are a provider in the community and you are with a patient and they are expressing just increased depressive symptoms, maybe they're just expressing overall imbalance with their mental health. If you feel like they do need that higher level of care, you can call the access unit, the number I provided, visit with them, and they can provide recommendations from there. If you feel that they are immediate danger to themselves, so if they're expressing suicidal ideations, homicidal ideations, especially if they have a plan, if they have intent, then it's probably a good idea to go ahead and call the non-emergent or 911, reach out to CIT if they're available, or have an officer come out. If you're in a rural community, the sheriff departments work really well with this as well. and have them assessed, have them brought in and assessed to the unit. And then from there, they can determine, do they meet criteria for inpatient hospitalization, or can we refer back out to the community, reach out to providers such as TPC, things like that. What am I missing, Meg?
I think you pretty much did a very brief overview of the Pavilion and how to get access to services. So thank you.
You're welcome.
Yeah. All right. So if I can have everyone from the panel pop in. If Shrey, there you go. We're having everybody. So I did have some general questions for the panelists, and one of the, and these are general situations which I think many people in the field can identify with. And so we're just going to kind of talk about them. So a lot of our people, we see this over and over again, is when we have people deal with the uninsured. Either they have no insurance or they're very poorly insured. And so they are not managing their mental health because they have no insurance or they're uninsured. And now they're in a crisis. What is the avenue for care for them? Obviously, Jennifer, you probably see this a lot,
Yes.
or you'll see that, or Devin, or I'm sure everybody sees this where they're like, no, you can't take me to the hospital because I don't have insurance and I don't want to see the pay, or they're not going to get a doctor, or they're not going to get medication because insurance. What are some of the avenues or some of the negotiation tactics that you guys try to do in order to still get care for the people who are in crisis, regardless of their insurance status?
Yeah, I can speak to our part of it. So, you know, a lot of times as policemen with our side of it, especially emergency detention, where someone is, you know, we deem them a danger to themselves or other, tells us we can take them into protective custody and transport them to the nearest health facility. Under that, we don't consider insurance status on that. But you know, that is a part of the system I think could be improved, because we have had folks before that we've taken to the hospital and they are upset because they've done this before and they've gotten a bill for it. And I feel there's a little bit of guilt in that, but that's the only avenue we have to, you know, help get someone out of a crisis and try to get them stabilized. But as far as the day-to-day, especially with the Intercept team under House Bill 13, we're able to provide grant funding for prescriptions and for counseling through TPC and services through TPC that initially are of no cost. And I know they have a sliding scale to kind of tailor that to who the person is that's needing those resources. But a lot of times we're able to get those medications, which is a big part of what we do, is just trying to keep folks on their medications or bridge the gap. They've gotten out of the pavilion and they've gotten out of somewhere and they're waiting on their caseworker to meet with them initially. But just because, again, of manpower, and we understand that on TPC as well, there's going to be a gap there. And sometimes folks need those medications a little bit sooner. And we're able to partner with Martin Tipton Pharmacy, and they work with us with our grant funding, and they'll get the medications to them. So a lot of times, you know, on the police side of it, insurance is not really a factor for us, but yet I do empathize with the problems and the monetary concerns of our folks that need those resources.
And so one of the participants just asked, like, for somebody who's homeless without insurance, is there a way or avenue for that person to get regular mental health for a chronic condition, such as maybe bipolar or schizophrenia?
As far as the inpatient level, when they come in, regardless of payer source, you know, we treat them, we provide medications and therapy. We have a group within the hospital called Med Data, and they will look at their clinicals, and if they feel like they meet criteria for disability, things like that, They do a really great job of meeting with them, getting that process started, and then following them even after hospitalization. However, we do see very often that, especially our homeless population, they just fall kind of in between, where they don't quite meet criteria for disability, but they don't meet, they're not 65, they're not meeting Medicare yet, things like that. So at that point, that's where our partnership with TPC kind of comes in, and I'll let David speak on that. But we refer directly to them, and they have someone reach out to them and get them established with services.
And what would be the procedure for IDD clients, if anybody knows?
As far as inpatient, it would work the same. We would coordinate with TPC to establish them with their IDD program. They have a very separate criteria as far as psychological testing to meet criteria, things like that. That we typically refer out to TPC IDD services.
Okay. And so also in regards to people who are uninsured and have no insurance, are there any other programs that we know about in the area that can sometimes help people with medications and or counseling programs in the region?
Sorry. TPC actually has a program that that's grant funded through the state. When somebody is outside of the Amarillo Hospital District, so anybody in our rural areas, if they don't have insurance, what TPC does, if my team, the MCOT team, does an assessment, what we can do is a rapid stabilization bed, which we're contracted with Northwest Texas Behavioral Health, Oceans, Amarillo, and Pampa Regional. So we can refer them to one of those hospitals, and we can pay, I believe it's anywhere between 5 to 7 days for their stays there. So that's one thing that we use out in the region when people are saying, I don't have the money to go to a hospital because it's that expensive. We can help fund that for them through that program.
Okay, very good.
Let me jump in there real fast. For our agency, for the mental health and wellness department, we do have counseling available to a lot of different people, certainly uninsured. We have several grants that can assist people that don't have the ability to pay. So we have a couple of grants for individuals who are victims of sexual assault if they have no way to pay. We are a recipient of the Victims of Crime Act grant. And so if an individual comes in and they're a victim of any type of violence or any type of crime, specifically, survivor of homicide, bullying, different stuff like that, they may qualify for that. Also, if there's been a police report generated, we assist folks in filing for crime victims compensation. CBC funding will pay for counseling services. And then we do also work on a sliding scale fee based on levels of income. So there are definitely multiple ways that we can assist. Also undocumented, these kinds of services for mental health, we definitely will serve undocumented. We're not talking about statewide or federal benefits. This is confidential. We're not reporting to anybody that they're undocumented. These are people in pain who have been victims of crime oftentimes or are dealing with mental health issues. And so we can assist with that as well. So some of those grants may not be appropriate for undocumented individuals, but we still want to be able to link them with services. So we try to focus on that as much as we can.
Well, thank you, Kathy. That kind of segue into my next question is that the services that you guys offered, are they also offered to the undocumented as well as documented people? Like, in other words, regardless to that the services that you guys offer limited to documented or undocumented immigrants?
At our agency, yes. And especially my department working with victims of domestic violence and sexual assault. We definitely work with undocumented individuals with that level of confidentiality. There's no issue of reporting. And certainly through that work, we can also assist them in applying for things like a U visa or an emergency visa to stay in the country. Because if their crime is committed or perpetrated by someone in our country, then they do have certain levels of relief based on that. So we do work with them here at Family Support Services.
And Kathy?
Work with them at Northwest as well, regardless of documentation status.
Okay, very good. And then I'm assuming that's the same at APD as well, yes. And what about at TPC? Documenting, do you have to be documented in order to receive services at TPC?
No, you do not have to be documented to receive services here.
Okay.
Our motto is, anybody in crisis, we're gonna.
Oh, no. Okay. I believe you're going to say that it doesn't matter if you're in crisis, you will receive services.
Well, David's frozen. Can I jump in there? It looks like someone asked about repeating information about police report and victim services.
Yeah.
Crime victims compensation, commonly known as CVC. If there's a report, a police report that's been generated because of a crime, we can assist, or a person can actually apply by themselves online through a portal with the Office of the Attorney General. You can apply for crime victims services compensation. There are certain things that would qualify as being reimbursable because of a crime, reimbursement for medications, help relocating to a new place if the crime happened in their home, counseling services, those kinds of things. So if there's a police report that's been generated because of a crime, crime victims compensation you should always apply. And you should always apply. There might be reasons why they would deny that, but always apply because those funds can really be helpful.
So my next question has to do with, you have another question, Kathy? Yeah, the rural area.
Yeah, we because of the pandemic, our counselors got pretty adept at doing telehealth. I believe that some of them still are conducting some telehealth sessions, and so it would be possible to do telehealth, by your cell phone or by a computer and things like that. Currently, our counseling services, I think, have a wait list of about 4 to 6 weeks, which, from my understanding, is kind of common with a lot of counselors out in the community. So. But we certainly will serve anyone that is seeking services. If they can come in and meet with us, that's great. We may be able to set up telehealth services. So if someone were to be calling our intake coordinator, Barbara, they should ask about that. Hey, can we do counseling over the computer? Can we do a telehealth session? Because we've been doing that since the pandemic started.
And Brianna, somebody will get back to you about getting you a link on more information on crime victim compensation. So my next question for the group is, what are the legal limitations do you guys face when you have somebody that's in a mental health crisis, the family is making a referral, but the person themselves don't want the help? For example, let's say it's me. I'm the one that needs the mental health. I'm clearly in a mental health crisis. My mom makes the call, but you come to the house and I'm saying, no, I'm fine, leave me alone. What do you do at that point? What's the limitation? How can you get involved if you can get involved?
So for law enforcement, there's 2 ways that we can legally take someone for an emergency mental health evaluation. And that is I kind of referred to it earlier, it's called emergency detention. And standard emergency detention would be if I came to your house and you gave me enough evidence or enough statements, or I can articulate based on what I'm seeing myself, hey, Meg's, a deteriorating condition, or there was some statements made she wants to harm herself, something along those lines, where I could say, I feel like there's not time to obtain a warrant, which is what the law says, and I have to take her right now and present her to the nearest appropriate mental health facility for treatment. Now, there's a second part of emergency detention where I have what's called a third-party declarant, or a credible person. And that would be like you're talking about that scenario. We see this a lot with folks that want to harm themselves. They're not like schizophrenic or delusional or anything like that, but they know that if they make those statements to me, they might have to go to the hospital. They might have to go to the Pavilion or somewhere like that. So they don't want to tell me the things that they might have told their family in confidence, because they don't want to go somewhere. And that a lot of times is where we can pull someone aside that's on scene, that heard something said, and they can actually go on record with us with an affidavit and onto the emergency detention paperwork to say, hey, I feel like this person's a danger to themselves because of this. And then that allows us to take that person right then as though we had heard the information ourselves. A third way to take someone on emergency detention is if someone goes and applies for a mental health warrant with the county judge. And so we see this a lot of times in deteriorating conditions, where someone calls and they say, hey, my significant person in my life has been diagnosed schizophrenic. They won't take their medications. They're not taking care of themselves. They're not eating. Their house is filthy. Whatever it is, there's documentation they can make. And we feel in those situations where it's not emergent that minute to go seize them and take them to the hospital, there is time for that person to go apply for a mental health warrant. A lot of times this is same day service, so to speak, down and talk to the county judge and get a warrant, and then they contact us and we go take that person into custody, just like we were there witnessing the behavior. So there's three different components where someone can be taken to detention, and there's two ways that persons outside of direct law enforcement can get that accomplished.
And for the other panelists, what would happen if, say, I was a minor or a geriatric and the family is not in agreement with the treatment or medication for the individual?
I think from our perspective, if a call to Child Protective Services or Adult Protective Services would warrant that, if the family's neglect is going to lead to some level of incapacitation or harm to that person, then obviously as mandated reporters, I think we all understand that there may be a necessary call that has to happen. So that would kind of be our perspective. And that's always hard. It's not that, that's one thing we always remind people, especially new folks that are interns and things like that. You don't have to know for sure it's that situation. I mean, that's what the investigation is for. But if you have a concern, if it looks like something that just isn't right, you make that report, you hand it over so that the people who investigate those can look into it.
Okay.
I will add, kind of on inpatient side of things, it's always important to really look at, is there a fear of the medication? I see that more often where maybe a teen is hesitant to start a new med, or family members are concerned if it's their geriatric loved one, how is this going to affect their dementia or their congestive heart failure? So really education is key. A lot of times if we take that time, take that step back and really see what is the concerns and have that addressed. If it's, like Kathy said, if it is going to be neglectful or it's going to cause them to mentally decompensate, then certainly a CPS or APS case would be, warranted for further investigation there. If it is a geriatric patient, I see this often on my unit. We always look at cognitive functioning and kind of determine if there's an impairment there. We assess for overall capacity to see is this patient their own decision maker, or have they been deemed unable to make those decisions due to dementia, Alzheimer's, things like that. And at that point, we go through the process of, is there a guardianship in place? Is there a medical power of attorney in place? And kind of reach out to the decision makers at that point.
Very good. So I would like to ask everybody if there's any last couple of questions for the panelists, because we do want to keep this presentation within the hour, and we do want to do a presentation of the website of all the mental health resources in Amarillo that has been created by the Panhandle Behavioral Health Alliance. So if there's any last question for the panelists. Okay, so we addressing homelessness and continuation care for mental health. So Brianna, can you tell us, I need to ask a little bit more about what is your question regarding to that? Like, how do we continue? So we do have, I know with Devin had a particular officer that is dedicated with the homeless outreach team. It's called a hot officer, not that he came out wrong. But he is hot, but not hot in that way. Yeah, please don't tell him I said that. But Devin is
So yeah, I can kind of answer
yeah,
that.
can you talk a little bit more about that team? But yeah, so basically Bria is asking about how do we get somebody who is homeless a little bit more stabilized and continue to get that person stabilized after they have one of those episodes and get them stabilized, and then if they remain homeless, how to keep them stabilized. And so I know that we have a homeless outreach team. And if you can talk a little bit more about that. So
Meg, if you don't, I'm just going to interject. I see that Chelsea Ray is also in the meeting. She's with Regions Health Network. So
okay.
I'm going to give her an opportunity. Chelsea, feel free to unmute your video or unblock your video and unmute your audio and stuff and kind of chime in on the RHN services.
Okay. So why don't we do that then? But in the meantime, I want to thank everybody for joining us this morning, especially the panelists, and then we can go ahead and move on to the next section.
It won't let me stop my video. Sorry to interrupt. Oh, here it goes.
That's okay. Just go ahead and speak then. I think Brianna was more interested on the outreach services. There you go.
Thank you, Pete.
So over here at RHN, we have the outreach program, which has to do with our homeless population. We just started to add mental health services back in October when I got this position. Kind of some of those services include social work, counseling, skills training, substance abuse, mental health. And we have 3 psych meds here. I'm hoping to get more as our program starts to grow more. All of this stuff is walk-in based. So if somebody comes in and they just came out of the pavilion and they need, you know, some Zoloft, I could get them started on some Zoloft. I could do a mental health evaluation and get diagnostics on them and start skills training all in the same day. That's kind of the availability of that program right now. And it looks like somebody asked for my contact. Let me put that in there. Let me see here, 344-7917. It's kind of a fairly new program as far as it goes. We also have physical health stuff here as well. So.
And I think your clinic is located right next to the TPC clinic too, right? It's off of Amarillo Boulevard.
Yes, we are at 713 North Taylor. We kind of work almost hand in hand a little bit too, like with TPC, like if they have more psych meds than we do. So if they want to start here, and then we'll funnel them into those services as well, if that's where they need to be. So
Thank you, Chelsea.
no problem. Thank you.
Rhiannon, hopefully that answers your question. If not, I think feel free to send there. Are there particular hours for RHN? Chelsea, if you don't mind, just kind of put that in the chat box. But I'm going to transition now. I just want to first say thank you, Meg, and thank you for all of our panelists for sharing your information and your insight regarding what we do to kind of help our community when they're in crisis. So now I'm going